Okay. So our destruction codes are based on the type of lesion. Okay, Vashmi, focus on my screen only right now. Okay. So our destruction codes are based on the type of the lesion. If it is a malignant, we have to follow the code from series 172. If it is a benign and pre-malignant, we have a three type of destruction code: benign, pre-malignant, as well as malignant tissue. Destruction means ablation. Ablation means to remove something with the external energy, whether it's a thermal energy, whether it's an electric energy, whether it's a laser energy. So when there is a removal of a lesion or the ablation of lesion, then we have to use these 17 codes for destruction. And these codes are based on the benign, pre-malignant, and the malignant tissues. So if the lesions are condylomata, papillomata,
Ma'am,
yes.
I'm sorry to disturb, but we cannot see your screen.
Oh, yes. And I think I missed to share my screen. Just give me. Samriti, you there? I think I'm not getting the option to share my screen. Just give me a second. Let's see what I have to do. Allow to record local files, chat.
Yep, yep. One second, let me check. You have the okay.
Samriti, you have to allow the screen sharing option on the Charanjit Ahuja. Like there is a different name.
Okay. Oh, okay. On the other one, is it?
Yes, yes.
Okay. I've given it to both. Can you check now?
Just give me a second. Yeah, now I'm getting the option.
All right.
Thank you. Okay, perfect. So Vaishnavi, are you able to see my screen now?
Yes, ma'am. Now it's visible.
Perfect. So as I already told you, for the destruction, we have a three types of codes: benign, pre-malignant, and malignant. These codes are based on the type of lesion, whether it's a benign lesion, pre-malignant lesion, or the malignant lesion. Here we have the type of the lesion like condylomata, papillomata. These lesions are considered as an benign. Pre-malignants are only the actinic keratosis, and rest all lesions will be considered as a malignant lesion. So we have these three type of the lesions. Now going back to your question. So I'm going to copy your question. Just give me a second. Copy image. So here we have the option, codes. So patient is 36-year-old male who presents to have a multiple lesions destroyed, three benign lesions. So three benign, five actinic keratosis. So actinic keratosis are the pre-malignant lesions. Okay. So five pre-malignant. So total eight lesions has been destroyed, three benign and the five pre-malignant. How we have identified that actinic keratosis are pre-malignant? Based on the instruction given here that pre-malignants are actinic keratosis. Now we have to find the code. So let's find out the code for the pre-malignant lesion first. So here we have the destruction code for the pre-malignant. For the first lesion, we have to use 1700, and for each additional lesion, we have to use 17003 till it's in 14 lesions. For more than 14 lesions, we have to use 177004. So we just have a 5 lesions, so we are going to consider the code from this section only. So 1700 and 17003, 4 units. We does not have this option in any other option. So the answer should be B only. And for benign, so let's see for benign. Here we have the benign lesions. So for code benign lesion, that 14 lesions are included in one code itself. So our code should be 17110. Vaishnavi, clear to you? Vaishnavi, are you clear on this point now?
Yes, ma'am. Got it.
Okay. Any other questions from the previous sessions?
Ma'am, I have another question too.
Mhm. Send that over the WhatsApp group.
Okay. Sent, ma'am.
Okay. This one is for the musculoskeletal section. Vaishnavi, we are not getting the complete options here. Can you send the other two options also so that I can mention here? There must be two other options. Oh, okay. I'm moving further. So whenever you have these type of questions where the question is too huge and you are not able to understand the question completely and not able to read the para completely. So in these situations, what you have to do, you have to refer the option first. So like in this case, we have these two codes plus option number C 29805 LT and 29806 LT. LT stands for left side. And the option D 29825. So whenever you have these type of questions where there is a huge question, a complete big paragraph in the question, in these scenarios, what you have to do, you have to refer the code first. So what we will do, we will refer the code first and see what is the difference between these codes, and then based on the question, we will correct, choose the correct code. So our first option is 23450. 23450. So 23450 is for the capsular FE, and this is an open procedure. This is not an arthroscopy procedure. Whenever there is an arthroscopy procedure, you will get the code from series 29. But the series is 23, so it's an open procedure. That means open approach has been used to perform the capsular FE with the incision. Next is 23466. 23466 is an capsular FE itself, but this one is for the glenohumeral joint, and this one is a anterior putty plat procedure, and this one is on the shoulder joint. Next, we have the option for the arthroscopy 29805 and 29825. Now, let's see the difference between 29805 and 825. Two nine eight zero five. 29805 is diagnostic procedure. So for diagnostic, we have a specific guideline diagnostic or separate procedure, that we will build a separate procedure only if there is a no therapeutic procedure performed on the same time and at the same location. So we are not going to use the option number C because we cannot build the diagnostic procedure separately in conjunction with the therapeutic procedure. 29806 is a therapeutic procedure. It's an arthroscopy surgical capsulotomy, and at the same location we are going to build diagnostic. So that's not going to happen. We have to build either therapeutic or either diagnostic. So when diagnostic and therapeutic performed on the same day, we have to build only the therapeutic, not the diagnostic. So our option C is completely rule out. Now the last option is 29825. 29825 is with the lysis and dissection of adhesion with and without manipulation. So this, the parent code for this code is arthroscopy shoulder surgical with the lysis of adhesions. Lysis of adhesions. Adhesions means the tissue has been joined with each other. Now let's go back to the question. Now we know the difference between these three options. Now we have to read the question to understand what is actually performing. Our question is, patient had the frozen left shoulder, arthroscope was inserted. So arthroscope was inserted in the glenohumeral joint. Cartilage was normal. There is a grade 3 or 4 changes. About 5% of humerus just adjacent to all the superior labrum were torn. Completely intact. Anterior portal was created. Rotator interval was very thick. And then arthroscope was placed, used to debride some posterior capsule. The arthroscope was then placed back posteriorly. This was done with the electro. Then arthroscope again is placed. So the complete procedure is performed with the arthroscope only. So Vaishnavi, tell me what should be the correct answer, A, B or D?
B, ma'am.
D as in Delta or B as in Bravo?
Sorry, I cannot.
D as in Delta or B as in Bravo? You have mentioned that answer should be D, right? D dog
Yes.
or yes,
B answer.
answer should be D only, not B. Because in the D, everything performed with the arthroscope, whereas in option B, everything is performed in via open approach. In our case, open approach was not performed. Everything done through the arthroscopy approach. So we are going to build the arthroscope only. We are not going to build the open. If in any situation, doctor started with the laparoscope procedure, or not laparoscope, with the scopy procedure, but at the end we convert that procedure to the open approach, then we are going to build the open only. Then we are not going to build the arthroscopy or laparoscopy approach. But here the complete procedure was done with the help of arthroscope only. So we are going to build only the option number D. So the correct answer should be D. Correct? Any doubts, any questions?
No, ma'am.
Any other questions? Any other questions? Gauri, Zamil, Sandeep, Shilpa, any other questions or shall we proceed with the new chapter?
No, ma'am.
Okay. So we are going to Gauri send some questions. Just give me a second.
Ma'am, can we solve this one question?
Okay, definitely. Let me pull that question in this. Okay, got it. So what's the question here? Gauri, any specific question or you want me to solve this question completely?
Ma'am, complete question.
Okay. So here patient is coming with the sacroiliitis, that means inflammation in the sacrum. There is a pain on the left sacroiliac joint and under the fluoroscopic guidance, needle was positioned. So fluoroscopic guidance was used. 80 mg dipometrol was inserted and into the left sacroiliac joint. Patient was able to walk for the exam room without difficulty. So what has been performed today? Only injection 80 mg dipometrol has been inserted into the sacroiliac joint. Now we have these four options: 20610, 7096 and 551. So let's proceed with rule out technique. First we have to go through with the each code to understand is happening in each code. So 27096. 27096 is an injection procedure for sacroiliac joint. This includes the fluoroscopy and CT guidance. That means it is on the sacroiliac joint. We have a specific code here. So we are going to use only 27096. So answer should be C only. We are not going to use this code option B because 27096 already includes the fluoroscopy guidance. It says with imaging guidance. So whenever imaging guidance is included in your main code, you are not going to build that separately. And if we talk about the other codes, 20610, 20610, when there is an arthrocentesis on the major joint, that means doctor is inserting and removing something from the major joint, then only we have to use the 20610, and 20551 is for the trigger point. I'm going to pull those codes also. Two zero six one zero. So you can see here, this was the arthrocentesis procedure on the major joint. So if we have a specific code for the sacroiliac joint, we are going to use specific. We are not going to use this one. And if we talk about 20551, this is a tendon injection. So this series is for the trigger point injection. So if there is a trigger point injection or a tendon injection, then only you have to use this series. So answer should be C. Got it clear to you?
Yes, ma'am.
Okay. Any other questions? Okay.
No, ma'am.
I'm moving. I'm moving further. Okay. So now we are going to start the new chapter for the digestive system. So at the beginning of these codes. Okay. So our next series is digestive system series. Our code begins from 40490 to 4999. This system includes the diagnostic and the definitive treatment procedure, such as GI endoscopy. This is our diagnostic, laparoscopy diagnostic. And the therapeutic also, like if with the laparoscopy doctor remove the hernia. So it's a laparoscopy procedure. So diagnostic and therapeutic, both the procedure has been performed. So we are going on the digestive system, gastrointestinal system. Then we are going to use a code from series 40490 to 499. So GI system, gastrointestinal. So this includes the digestive tract. Digestive tract means esophagus, lips, stomach, duodenum, small intestine, large intestine, as well as the accessories organ. Accessory organs such as pancreas. So if any procedure performed on the pancreas, liver, and gallbladder, we are going to find the code from this section only. So for GI system as well as for the accessory organs, we are going to find the code from this section only. So this section begins from the lips and then esophagus, vestibule of mouth, and so on. So you can see here, first we have a section lip, then vestibule of mouth, tongue, dental, palate, and so on. And each section, first we have a code for the excision, repair, then other procedure. Excision, repair, other procedure. Excision, repair, other procedure. We do have the option for the incisions also, but there are few where we have the incision, but first we will get the codes for the incision, followed by excision, then repair, and then any other procedure of that section. So let's start with the lips first. Here we have the lips. So in the lip, our codes begins from 40490 to 4761. 40490 40761 codes represent any procedure performed on the lips. So basically lips are composed of skin, muscle, mucosa, and then it is divided into the three main regions such as cutaneous, vermilion, and then mucosal. So cutaneous means skin area, vermilion border. Let's say this is the lips. So the vermilion border and the mucosa area, the internal part of the lip. So cutaneous portion of upper lip extend from the bottom of nose to the nasolabial floor, such as like vermilion border. So vermilion border, this is the vermilion border. So any procedure performed on the cutaneous part, vermilion border, and the mucosal part of the lip, then we are going to code from series 40490 to 40761. Our first code is biopsy of lip. We are going to use this code if biopsy is performed on any portion of lip. Any portion of lip. Starting from the vermilion border, continuing inside the mouth or mucosal area. So we are going to consider it as a biopsy of the lip. So we have to perform the biopsy when there is a concern such as malignancy and plaque is there or any other lesion, and we have to identify what type of lesion it is. If there is a malignancy or non-malignancy, then we have to do the biopsy of lip. So we are going to use 4090 when open biopsy is performed. Open biopsy means specimen has been removed with the incision with the sharp tool. Then we are going to use the 40490. If FNA is performed on lips, then we are going to use a code from series 10021. For FNA, we have a specific series 10021, and FNA we are going to build with that code only. We are going to use these codes if it is an open biopsy of the lip. Next code is vermilionectomy. Whenever there is a suffix ectomy, ectomy means removal. Suffix ectomy means okay. So suffix actiny means removal, and vermilion means the vermilion border of the lip. So whenever there is a removal of vermilion, then we are going to use 40500. 40500 also includes the mucosal advancement. Mucosal advancement means the grafting of the mucosal area. So it includes the repair of the excisional area as well as the mucosal advancement. So if the more tissue has been excised from the lip area, and after the advancement, we have to uh, do the repair with the mucosal advancement. Then we are going to use 40500. Then we have these four codes: 510, 520, 525, and 527. These four codes are the resection or excision of lip. Excision or resection of lip. So when the lip has been excised, which includes the cutaneous, vermilion, and the mucosal area, when these three areas from the same site has been removed, we are going to use the 40510 series. This series is based on the type of excision. First we have wedge excision, then we have V excision, then we have full excision. So the wedge resection or the full thickness excision means, wedge means triangular shape has been removed. So if the specimen has been removed in the triangular shape, we are going to use is wedge excision. If it's a V shape excision, we are going to consider 40520. When the full thickness has been removed, then we are going to consider 40525. Then these codes are with the flaps also. So if it is in local flap, 40525. If it is in cross lip flap, flap means another tissue has been used to close that excision or that incision. And based on the flap, we are going to use a specific code from these codes. So if it is in local, 4525, cross lip 27. If it is more than 1/4 and without restriction, doctor is not doing any kind of reconstruction there. Not advancement, not flap, nothing. Then we are going to use 40530. This one is without reconstruction. Next section we have for the cilioplasty. Whenever there is a suffix plasty, plasty means plastic repair. Plastic repair. And the cilio means lip. So when there is a plastic surgery of lip, that is cilioplasty. We have the code 40650 to 4761, 40650 to 40761. Let me see if we can put these codes in the one screen. These are the codes for the cilioplasty. These codes are based on the vertical height of the lip or the repair. So you have to see how much vertical height has been repaired. Just example, up to half vertical height or over the half vertical height. So these procedures are basically performed for the congenital conditions such as cleft lip. If there's a cleft lip, doctor is going to repair the lip, or any particular injury, any particular disease. So when doctor needs to do the plastic repair of the lip, we have to use these codes. So these three codes are based on the vertical height. These three codes are based on the partial or complete, bilateral, one stage, or two-stage. So if it is a two-stage procedure, doctor planned that first we are going to use this one, and then after 5 days we are going to do this part of the procedure. So it's a two stages procedure. Then we are going to use 40702. Then secondary means patient had a left lip repair earlier. Now patient is coming again for the secondary repair. Then we are going to use 40720. And in the last we have this 40761. This one is that after the plastic repair or the plastic repair has been performed with the cross lip pedicle flap. So the tissue has been picked from the another area so that there is a flap has been created for the reconstruction. So flap has been used for the reconstruction. So in the flap, what happens? Another living tissue has been moved from the one bottle to the another so that we can restore the shape and the function of the previous organ. So the plastic repair has been performed with a cross lip pedicle flap. Then we are going to use 40761. Can any of you tell me the difference between the flap and graft? We have two type of words, flap and graft. Let me mention it here also, flap and graft. Why we are using flap word here, not the graft? Any answers? What is the difference between flap and graft?
Ma'am, one like graft only includes upper layer like epidermal, and flap may include deeper portions of the skin.
No, that's not always the case because we have the bone grafts also, right? So graft means taking the tissue from the other side of the body without the blood supply. Okay? Without blood supply. And the flap means the tissue has been advanced, such as, let me show you the picture. In the flap, blood supply has not been cut or removed. Flap. Let's see cross lip flap itself, okay? Cross lip flap. Just okay. So what's happened in the cross lip flap? We will pick the tissue from here, and after picking the tissue from here, we will place that here. That means we are not going to remove the blood supply of that tissue. We are just moving that tissue from that another area so that we can give the better cosmetic outcomes or better function of that area. So the difference between the flap and the graft is just in the graft, the complete blood supply has been removed, whereas in the flap, blood supply is not removed, just tissue has been transferred from the one place to the adjacent next or the next place. Clear? Everyone is clear with the difference in the flap and the graft? Good. Let's move further. Okay, let's move to the next section. Vestibule of mouth. Tongue, floor of mouth, dental liver structures. So, vestibule of mouth. Vestibule of mouth is space between the cheek, lip, and teeth. So, the internal portion, the space between the cheek, lip, and teeth is referred as an vestibule of mouth, or we can also call it as buccal cavity. So, any procedure performed on the vestibule of mouth, dental structures, as well as palate, salivary glands, ducts, or these are the accessories organs. We are going to use a code from series 40800 to 42699. That means 40800 to 42699 codes includes any procedure performed on the dental structure, palate, salivary glands, ducts, floor of mouth, tongue that covers these type of procedure. Now let's start. So in this section, first you will get the code for the incision, then excision, then other procedures. So first we will get the section for the incision, excision, and then other procedure. In the incision, we have 1, 2, 3, 4, 5, 6 code. Our first code is drainage of abscess, cyst, hematoma from the vestibule of mouth. You will get this drainage of abscess code from each series, and your code is based on the location. So if there is a drainage of abscess from the bone, you will get the code from 2 series. And if the drainage of abscess is performed on the kidney, you are going to get the code from the 5 series. We have to use this code when there is a drainage on the vestibule of mouth. First we have simple and then we have the complicated. The difference between the simple and the complicated are just if the more than one incision is required to drain that abscess, then we are going to consider 40801. Or not just the incision, if after the incision doctor need to place the drain so that there is no pus accumulation after the drainage, then also we are going to consider it as uncomplicated. So 40800 drainage of abscess, 40801 it's for complicated. Next we have 804 and 805. 804 is removal of embedded foreign body, vestibule of mouth, simple and complicated. Foreign body means anything which is entered into the patient's vestibule of mouth which is not performing any particular purpose or any intent, that is foreign body. So if the doctor is removing it with a simple incision, then we are going to code 40804. You have to remember this section is for the incision. So whenever doctor is just doing the incision to remove the abscess or to remove the embedded foreign body, we are going to use these codes. The difference between simple and complicated is just the number of incision. If more than one incision is required to remove the foreign body, we are going to use 40805. If it's only one incision, we are going to consider it as an 40804. Next, we have 40806, incision of labial frenulum. So it is also known as frenotomy. Otomy, whenever there is a suffix otomy, that means only incision has been performed, nothing else. Only doctor did the release or just mark the incision there. So whenever there is an incision on the labial frenulum, uh, then we are going to code 40806. Next section we have excision and destruction. So 40808, biopsy vestibule of mouth. Simple biopsy performed with the open approach then we are going to code it 40808. 40810, excision of lesion of mucosa and submucosa and vestibule of mouth. Excision of lesion. That lesion has been excised from the vestibule of mouth, which includes the mucosa and submucosa part. Without repair, 10. If it is with simple repair means one layer closure. If it requires only the one layer closure, we are going to consider with simple repair. If more than one layer closure are required, then we are going to consider complex. And if more than one layer is there, however, also there is a underlying muscle excision out there, we are going to consider it as an 40816. Then we have 40818, 819, and 820. 40818 is excision of mucosa of the vestibule mouth for the donor graft. So mucosa has been removed to for the donor graft. Like we have to place that mucosa somewhere else. Excision of perineum. So earlier we had this word pherenotomy. Otomy means incision. Ectomy means removal. So frenectomy as well as frenectomy and femectomy. These are the same words. When the frenum, labial or buccal cavity excision is there, we are going to quote 40819. Then we have destruction of lesion. If there is any scar in the vestibule of mouth or the adhesions in the vestibule of mouth, and we are going to destruct those with any other energy such as thermal, laser, cryo. Cryo means ice energy, cold energy, chemical energy. Then we are going to fill 40820. These all codes are for the vestibule of mouth only. So vestibule of mouth is the location between the cheek, lips, and teeth. This is vestibule of mouth. Okay. Next we have the repair section. This is also for the vestibule of mouth. These codes are very word to word, so I'm not going to discuss each code from here. Okay, we can discuss these 484 to 4845. These vestibuloplasty. So vestibuloplasty is performed to restore alveolar ridge height. So what happens here? We have to lower the muscles attached to the buccal and labial and then lingual aspects of the jaws, and then the floor of the mouth, we have to remove that separately. So these codes are based on the anterior, posterior, and the posterior bilateral. If the incision made in uh, interiors, front area, that is interior. If it is performed on the back area, that is posterior. So these codes are based on the approach, whether it's an interior, posterior, unilateral, or bilateral. Next, we have the tongue section. Tongue and floor of mouth. Tongue codes begins from 4100 to 41155. The prefix used for tongue is gloss. So let's say there is a word glossectomy. Glossectomy means removal of the tongue. So first section we have incision. In the incision, all these procedures are performed on the tongue or floor of mouth. So earlier also we have a code for the drainage of abscess, but that was from the vestibule of mouth, and this one is to the tongue or the floor of the mouth. So then with the help of intraoral incision, there is a drainage of abscess or cyst or hematoma. We are going to use a code from 41000 to 41009. So this one is a lingual space. This one is sublingual, superficially deep, submental space. So basically sublingual space is under the tongue. Let me mention it here. Sublingual means under the tongue. So sublingual space is under the tongue. Submandible space is under the mandible. Sub means under, mandible. So under the mandible, and the masseter space is between the floor of the mouth and the hyoid bone. So space between the floor of mouth and hyoid bone. Then we are going to consider it as an 41009. So next we have 41010, incision of lingual frenulum. Earlier we were talking about the vestibule of mouth. This one lingual. Lingual means tongue frenulum. So if there is an incision in the tongue frenulum, we are going to consider a code 41010. If it is on vestibule of mouth, we are going to quote the previous one, which we had discussed under the uh, vestibule section. Okay. Next we have the previous one is intraoral incision. This one extraoral incision. Intraoral means inside the mouth. Extraoral means above the mouth, like not inside the mouth. Okay. Next we have placement codes. So I'm going to do all these codes. Next we have excision. Excision means biopsy of tongue, interior 2/3, posterior 1/3. This one is biopsy via open approach. This one tongue, floor of mouth. So we have a two different code, one for the tongue and one for the floor of mouth. So 41100 is excision of lesion of tongue without closure. This one is with closure, and this one closure with the tongue flap. That there's a tissue has been used from the tongue itself to close that area. Then we have excision of lingual frenum. This one tongue frenum. Earlier we had a code for the normal frenectomy. This one is for the tongue frenum. Excision of lesion is a very simple one. So now let's move to the glossectomy. Glossectomy means surgical removal of all or part of the tongue. So if there's a removal of a part of the tongue, we are going to consider it as an call it as an glossectomy. Glossectomy means removal of tongue. So if less than one half, 4122. If it is an half tongue removal, 41300. So basically these codes are based on the extent of the tissue is removed. So that we have to see how much tissue has been removed. This one partial, complete, with or without tracheostomy. Tracheostomy means creating an opening in the trachea. So if hi, is it audible? Hello.
Yes, ma'am. Yes, ma'am.
Okay, I think there is some internet issue. I don't know till how long you guys are able to understand. So are you guys able to hear the glossectomy part?
Yes, ma'am.
Okay, I'm going to send one question for the glossectomy, then we will proceed further. Try to solve this question. This is for the palatoplasty. Our next topic should be palatoplasty. So just try to solve this question. It's 4-7. One more minute, then we will discuss this question together. Any other answers? Shifali, Vaishnavi, Gauri. Okay. Sandeep, any answers? Okay. Now let's discuss this question together. So Zamil, you did it very well. The correct answer should be A, B only. So let's see why should be the B. Okay, Vaishnavi, can you tell me the difference between modify 52 and 53? If any one of you can tell me the difference between the modifier 52 and 53. I think we discussed the modifier 52 and 53 in the last chapter itself. Last chapter.
Yes, ma'am.
Do
52 is reduced services,
mm-hmm,
like partially or eliminated completely, and
mm-hmm.
53 is uh, like discontinued procedures. Uh, like in this case, surgeon terminates uh, the surgery.
Exactly. So Vaishnavi, we have to use 52 when the doctor eliminates the procedure or partially reduce the procedure intentionally. If there is any condition to the patient and doctor need to discontinue that procedure due to the patient's well-being, then we are going to use the modifier 53, not the 52.
Okay, ma'am.
Clear? So the answer should be B only. You guys got the correct code, but the modifier should be 53 instead of the 52. Okay, now let's move to the another part. After the glossectomy, we have the next section, palate. Now, as we are left with just 1 hour, so I'm going to cover the important part where we have the guidelines. Okay, so our next section is palate. So first we have the incision, the drainage of, in this we just have the one code, drainage of abscess from the palate or uvula. And then we have a excision part, biopsy, open approach, excision, excision of the lesion, Simple primary closure means one layer closure. This one flap closure. If it is in graft has been used instead of this local flap, graft means a tissue has been used from the another area, then we have to use these codes for the skin graft. For the mucosal graft, we have a specific 40818. Next, we have the repair section. Repair, laceration of palate. So these two codes are based on the size of laceration. If it is in 2 centimeter, we are going to use 42180. If it is in more than 2 centimeters, we are going to use 42182. Then we have the codes for the palatoplasty. The palatoplasty for the cleft palate 200 and 205 with the closure of alveolar ridge, and this one hard palate. So these palatoplasty codes reports the uh, removal of the palate, uvula, pharynx. So we have a one code for the palatopharyngoplasty 42145. What is that? 42145. Look at it. So this palatopharyngoplasty, also known as uvulopalato-pharyngoplasty. So in this, uvula, pharynx, and the palate, all, all these three things has been repaired, then we are going to consider it as a palatopharyngoplasty. Next section, I'm not going through with each code because these are the same type of codes which we have just discussed. So I'm directly moving to the endoscopy section. 431. Because for till 4299 we have a code for the mouth procedures only. So I'm going to the endoscopy now. That is 43180. So endoscopy procedure. Endoscopy procedure are used to visualize the digestive organ through the scope. And now what is scope? It's a flexible fiber optic tube with the camera or with the instruments also, which has been inserted into the patient's body to the natural orifice or the natural opening to see if there is any particular condition such as ulcer, inflammation, tumor, polyp, bleeding or something. And if at the same time doctor is doing any procedure, any therapeutic procedure, such as if there is a bleeding and doctor is doing the cauterization with the help of endoscopy, then you are going to build the therapeutic procedures only. You are not going to build the diagnostic. So let me show you the picture of the endoscopy. So yeah, so it's a technique where the normal fiber optic tube has been used. Just look at it. So the tube has been used with the help with the camera, and that has been inserted into the patient body. So this is a fiber optic tube. Here we have the camera inserted into the patient body through the natural orifice, and to see if there is any particular condition in the patient's body. So if during the procedure, here we just have the two guidelines which we have to make sure that we have to follow in all situations. The first guideline is we cannot bill diagnostic and therapeutic procedure at the same time for the same location. So we cannot build a diagnostic and therapeutic procedure at the same time for the same location. This is our first and main guideline. Next is if bleeding occurs as a result of endoscopic procedure, and then we are not going to build the control of bleeding separately, because If it is done as an iatrogenic injury, that means done during the procedure, that means we have to build the normal diagnostic procedure only. We are not going to build the control of bleeding because it is not the patient's condition. It happens during the procedure itself. So we have to build a control of bleeding procedure only if the patient is coming for the bleeding control. If the bleeding is due to the endoscopic procedure, then we are not going to build that separately. Okay. So we have to follow these two guidelines in all endoscopic procedure. I have to show you one more thing here. Just a Okay, so we have to talk about the endoscopy now. Just so our endoscopy procedure, we have to follow two guidelines, which I've already told you. Now our endoscopy procedure are based on the location. Like the other court, other procedures, those are also based on the location. In the same way, our endoscopy procedures are based on the location itself. Let me open one PDF to show you something. I just over here. Mhm. Multiple. I have to share it first. Okay. So as I already told you, that our endoscopy procedures are also based on the location itself. So if the endoscopy procedure is performed on the esophagus, so esophagoscopy means visualization of esophagus through the tube, and it includes the examination of cricopharynx muscles. So if it reach to the gastroesophageal junction or the proximal region of the stomach, you are going to consider it as an esophagoscopy. So you are going to build the esophagoscopy if it's reached till the proximal stomach, proximal stomach and withdraws from the stomach itself. If it does not reach till the level of stomach, till the proximal stomach or till the level of cricopharyngeus muscle, then sorry, not crico, to the gastroesophageal junction, then we are going to build it with the modifier 52 or 53 based on the uh, report, whether it's supposed of 52 or 53. Next, we have the esophagogastroduodenoscopy. That means you are going to build the EGD if the scope reaches till the second portion of the duodenum. If the scope reach to the second portion of the duodenum, then we are going to call it as an esophagogastroduodenoscopy. If it reach to the jejunum or small intestine ileum, then we have these two series. Remember, if the scope is reached till the stomach only, or the first part of duodenum. It does not reach to the second portion of duodenum. Then you have to use the 52 and 53 based on the documentation. So whenever you are going to build the esophagogastroduodenoscopy, you have to make sure that your scope reach till the second portion of the duodenum. Second portion of duodenum. If scope does not reach to the second portion of duodenum, then you have to use the modify 52 and 53 based on the documentation. Next section 44360 to 44379. This is small intestine. These two are for the small intestine. This is also known as enteroscopy. Small intestine known as enter. So if there is a prefix enter, that means it is representing small intestine. So if it is till the jejunum, 4373. If it is till the ileum, we have a specific code series for the ileum. Next section we have, if it reaches to the, no, let's see here. So small intestine has been completed till here. Next we have these codes for the large intestine. These codes are for the large intestine. The prefix we have to use for the large intestine is colon. So first is colonoscopy. We have to build colonoscopy if it starts through the rectum and reaches till the level of cecum, then only we are going to consider it as an colonoscopy. Let's say this is in cecum and this one rectum. If the scope is inserted to the rectum and reaches till the level of cecum, then only you are going to bill it as a complete colonoscopy. If the scope does not reach to the cecum, then we have to use the 52 and 53 modifier based on the documentation. So whenever you are going to build a colonoscopy, you have to make sure that scope reaches to the level of cecum. So rectum to cecum. If it does not reach to the cecum, or physician is unable to advance the scope to the level of cecum, then we have to use the modifier 52 or 53. We do have a codes for the proctosigmoidoscopy and the sigmoidoscopy separately. Proctosigmoidoscopy is an examination of rectum or the proximal portion of the sigmoid, and we just have these four codes here. And the sigmoidoscopy we are going to build when the scope reaches till the level of descending colon. So if the scope reaches till the level of descending colon, then we are going to consider it as a sigmoidoscopy. We are not going to call it as a colonoscopy. We have to build colonoscopy only if it reaches to the cecum. If it does not reach to the cecum and reach till the level of what we call till the sigmoid colon or the rectum, or does not reach to the descending colon, then okay. Now let's move further. Endoscopy procedure. So these are the few guidelines for the endoscopy procedures which we have to follow. Procedures like venous access, infusion, injection, oximetry, anesthesia during the endoscopy procedure is always included in the endoscopy procedure. We are not going to bill these separately. If, as I already told you, it's at the same location, therapeutic procedure and the diagnostic procedure performed, we have to build the therapeutic only. We have to build the therapeutic only, diagnostic always included in the therapeutic. And if at the same session there is a more than one therapeutic procedure performed on the same bill area, or not same bill area, same location, we have to bill that only once. If there is a different intent or a different reasons, then we have to use this with the modifier. Our small intestine codes ranges from this to this. So these are for the enteroscopy, which we have already discussed. Okay. Now next, and the main part is ERC. I'm going to pull the codes for the ERCP here. So first we have a code for the esophagoscopy. So esophagoscope. After the esophagoscopy, we have the code for the EGD. That is, scope has been inserted till the second portion of duodenum. That is EGD. After the EGD, we have a codes for ERCP. That is endoscopic retrograde cholangiopancreatography. Okay. So our ERCP codes begins from 43260 to 43278. 43260 to 278. Here Here we have to use a combination of endoscopy as well as the fluoroscopy to treat or to identify a certain problem of the biliary area or the pancreatic or the ductal system. So basically, we have to use the ERCP to find out any particular condition in the bile duct, pancreas, any ductal system, gallbladder, so which includes the gallstone, inflammatory conditions such as scars, leaks. So basically, ERCP is used for the diagnostic purpose as well as the therapeutic region. Therapeutic region, we can treat the patient with the ERCP. So our ERCP codes are based on the ductal system. We have two systems here, pancreas and biliary tree. So whenever we have to build the ERCP, diagnostic endoscopy of the hepatic and pancreatic system, if it is performed separately, then we have to build as them separately. And we are going to consider the ERCP complete if one of the ductal system is completely reviewed. So an ARCP is considered complete if any one of these two ductal system is completely visualized. We are going to consider it as an ERCP, completed ERCP. If ERCP is not completely performed or on the one ductal system, then we have to use a 52 or 53. Let's say if there's a ERCP but cannulation is not completed, then we have to use the normal EGD codes because cannulation is not completed there. So for ERCP, we have two ductal system here, pancreas, which includes major and minor ducts, and biliary tree, which includes common bile duct, hepatic duct, right and left hepatic duct, cystic duct, or gallbladder. So if there is a stent placement in conjunction with the ERCP, then we are not going to build the balloon angioplasty, balloon dilation, because balloon dilation is always included in the stunt placement. So if we are going to build the stunt placement of the same location where the balloon dilation has been performed, in that case, you have to build the stunt placement only. You are not going to build the balloon dilation in conjunction with the ERCP. Okay. If more than one stunt exchange during the same session, we have to build that separately with the 59 modifier. And if the stunt has been performed different location and the balloon dilation has been performed at a different location, then you can build both with the modifier 59. Okay. Let's see if I have missed any guidelines. We have covered this one. But the next thing is if the biopsy is performed followed by the therapeutic excision, destruction, removal of the biopsy lesion, then the biopsy is included and considered as an integral part, and you are not going to build the biopsy separately. Let me see if we can find any particular code for the ERCP because this is a little bit difficult. Just give me a second. Ah, 43267. Okay, I found one question. Try to solve this question. Any answers? It's 4 minutes already. Any other answers? So, Amit, I have highlighted one thing here. Just reconsider your answer once. Okay. Now let's discuss this question together. I'm going to copy it here. Okay, now let's discuss this. So patient is 32-year-old, now coming for a surgery. It does not have any systemic disease, doesn't smoke, and regularly exercise also. He is prepped and taken into the operating room. Surgeons performed an endoscopy ERCP with the insertion of nasobiliary drainage tube. Within the same operative session, doctor also did the springectomy, otomy, sorry, not ectomy, it's otomy. And now they are asking how you are going to build this school. So 43262, let's see what is this 43262. Just okay. So 43262 is with springectomy and papillotomy. And 260 is a diagnostic. You have to remember one thing always. You cannot build a diagnostic and you cannot build the therapeutic procedure at the same time. So answer B is completely ruled out because we cannot build the diagnostic as well as the therapeutic procedure at the same time. So B has been ruled out. Diagnostic always states separate procedure. This separate procedure means we can build this procedure only if it is performed lonely. If it is performed in conjunction with any other procedure, then we are not going to build this. So 43262 just says that it's a springectomy, but in our case, tube is also placed. So let's see what other options we have. Next, we are left with 274. So let's see what is 274. So 43274 includes the endoscopy stunt placement and sprenotomy. That means both the things are included. So the tube placement, endoscopy stunt placement, which is a tube placement, as well as the sprenotomy includes in 43274. That means we have to build the 43274 only. So answer should be D only. We cannot build with the 43262 because this already include this one. And here also we have this instruction that we cannot build 43274 in conjunction with the 43262. Clear?
Yes, ma'am. Yes.
Yes, ma'am.
Correct it you? Okay, perfect. So the answer should be D only. And you have to make a note for the digestive system that if you are going to build a diagnostic and the therapeutic, if the both conditions or both the things happens in the same session, we have to build a therapeutic only. We are not going to build the diagnostic, as diagnostic is always included in the therapeutic procedures. Now let's move to the next topic. So our endoscopy topic has been completed. So after the endoscopy procedure, our next main topic is allotransplantation. I'm going to pull that quotes. Allotransplantation means intestine transplant, liver transplant. These are the allotransplantation procedures. Just give me a second. Let me pull those codes here. Also, we do have a codes for the laparoscopy procedures also. So the difference between the laparoscopy and the endoscopy. In the endoscopy, scope has been inserted through the natural or artificial orifice. Whereas in the laparoscopy, scopes has been inserted through the abdominal cavity. The scopes has been inserted through the what we call abdominal cavity. Then we are going to call that procedure as a laparoscopy procedure. We do have a word laparotomy. Laparotomy means incision in the abdominal cavity. But the laparoscopy means inserting the scope through the abdominal cavity. So if the scope has been inserted through the abdominal cavity, then we are going to call it as a laparoscopy procedure. Okay. Also, like I mentioned that in the endoscopy procedure also, diagnostic is always included in the surgical or the therapeutic. In the same way, for the laparoscopy, you are going to build a laparoscopic diagnostic only if there is a no surgical or the therapeutic procedure performed on the same date of service. If it is performed on the same date of service, then you have to build the therapeutic only. You are not going to build the diagnostic one. So these are the colectomy procedures. Look, this is a laparoscopy surgical for the enterolysis. Enterolysis means freeing the intestinal adhesions. This is also a separate procedure. That means if there is any other major procedure performed on the same type in the same area, we have to build the major procedure only. Further, these are the colonoscopy procedures. Okay, now here we have the allotransplantation. So any organ transplantation includes the three different components. Any transplantation. So the first transplantation is first part of that three components is cadaver, donor, or even the living donor. So the first part is we have to identify the donor and need to harvest the graft from the donor's body. So if we have to remove the graft or pick the graft from the donor's body, we have to harvest that. So our first step is harvesting of the organ or cold preservation of the organ from the donor's body. So if it is in cadaver means non-living, we have to use 47133. If it is in living, we have a 4713 for the living one. After the donor, we have to do the backbench work. Backbench work means it's a standard preparation of the graft prior to the transplant, which includes the removing the adjacent tissues or adjacent fats or surrounding soft tissues to prepare well for the grafting. So preparing the grafting or preparation of the whole graft or liver graft before placement is known as the backbench work. It's a standard preparation, okay, of every graft, not just liver, because any transplantation includes these three parts: donor work, backbench work, and then recipient work. So once the organ has been prepared to transplant, so after the transplant, after the organ preparation, we have to transplant it into the patient's body. Then we have a code for the recipient liver allotransplantation, which includes the removal of the previous organ and implanting the new organ into the patient's body. So if doctor is implanting the new organ and removing the previous one, then we have to use this recipient liver transplantation. So you can see here, this one is donor hepatectomy, this one is from the cadaver, and this one is for the living donor. So after the donor hepatectomy from the living and from the donor, other code section includes the backbench procedure. The backbench procedure includes removing of surrounding soft tissues, preparing the veins, portal veins, hepatic arteries, and everything. And then these are the backbench procedure. So backbench, the previous one is for the cadaver and this one for the living donor. So backbench procedure of the living donor. And after the backbench procedure, we have a codes for the transplantation, which I showed you earlier. So any allotransplantation includes three procedures: first donor, then backbench work, and third recipient hepatectomy or the recipient location placement. Okay, so after that, let's see how important we have here. External catheter placements. So dilation ERCP is completed. Laparoscopic we have discussed. So one more time, laparoscopic always with laparoscopy. We don't need to do that separately. So next important thing we have here. Just a second. Okay, one more thing I missed, that appendectomy guideline. Let me pull those appendectomy. Here we go, appendectomy. So for appendectomy, we have two sections, open and lapro. So for open, we have three codes. If it is in complete removal of appendix 44950, if it is done in conjunction with the other main procedure, then we have to use the add-on code 44955. And if doctor need to remove the appendix for the ruptured appendix, then we have to use the 44960. So 44960 for the ruptured appendix, 950 for the complete appendectomy, and 955 if it is done in conjunction with the any other main procedure. And if the appendectomy has been performed with the laparoscopic approach, we just have
Ma'am,
the one code. Yes,
ma'am, can you tell me the page number?
page number, yes, I think it is 414 based on the PDF. And if we talk about the hard copy, it is 378.
Okay, ma'am.
Jamin, shall I start talking or you need some
Yes,
time
ma'am.
to pull that code? Okay.
No, ma'am.
So
Okay.
again,
You can start, ma'am.
okay. So again, for appendectomy, we have two types of code, one for the open approach and one for the laparoscopic approach. For the open approach, we have three codes, 950, 960, these two based on the disease. If it is for the ruptured appendix, we have to code it 960. If it is an open appendectomy, 950. And if it is indicated with any other major procedure and not separately done, then we have to use this add-on code. Add-on code means we have to build this in conjunction with the any other main procedure performed in the abdominal cavity. And for laparoscopy, we just have the one code. If the appendix has been removed with the laparoscopy approach, we are going to build 44970. So any other doubts, any questions? Who does not have anything else in this chapter? Let me see if I missed something else. Just give me a second. Huh? I have covered appendectomy, colonoscopy, laparoscopy. We can talk about the hernia procedure. Just give me a second. Let me pull the codes for the hernia. So here we have a code for the hernioplasty, also known as herniorrhaphy or herniotomy. These codes are based on the type of hernia, whether it's an inguinal hernia, femoral hernia, lumbar, omphalocele interior, as well as the initial or recurrent. Initial means the first time repair, recurrent means it has been reoccurred at the same location. So whenever you are going to build the herniorrhaphy, first you have to see the type of the hernia, that where the hernia is, and then you have to see whether it's an initial repair or the recurrent, and then reducible or strangulated as well as incarcerated. So strangulated means it's stopping the blood supply or affecting the blood supply, whereas reducible means that we are able to reduce the hernia. So whenever you are going to build the herniorrhaphy, you have to first see the type of hernia, age of the patient, as well as inguinal hernia, femoral hernia, or the location of the hernia. So these three things you have to make sure before billing for the hernia. Any questions in the hernia topic? Any questions, any doubt here?
No, ma'am.
Okay. If there is no doubts, then we can wrap this session. I have already shared the notes with you, and I will share the questions in just few minutes. Okay. Thanks everyone. Bye bye.
Thank you so much, ma'am.